This section of the toxicology curriculum will focus on toxicologic investigations. Let's start with a case. This is a 56-year-old man who was found unresponsive in front of a local homeless shelter. His GCS was 3, heart rate 120 beats per minute, blood pressure 80/40, respiratory rate of 6, oxygen saturation 78% on room air, and a temperature of 36.2 degrees Celsius. In addition to ABCs, his initial management included intubation. The question is this a toxic exposure, and what investigations should be done to help determine this? Over the next 10 minutes, we will talk about a general approach to toxicologic investigations. This would include consideration of basic lab tests, including the calculation of an anion gap and osmolar gap, the role of toxicology testing in both urine and serum, as well as other tests such as ECGs and X-rays. You will see that not all tests are necessary or appropriate for all toxicology cases, but should be ordered when needed to aid in clinical decision-making. Many patients will have basic blood work, including a CBC, electrolytes, and renal function as part of their initial workup. These results can be important clues to underlying toxicologic cause of their symptoms. For example, a low bicarbonate level on the electrolyte panel may suggest an underlying metabolic acidosis and should trigger the collection of a blood gas and calculation of an anion gap. The anion gap is a useful tool to identify unmeasured anions, and together with the calculation of an osmolar gap can be an important clue to the presence of a number of toxins. In keeping with the usual approach to any patient, anyone with altered mental status should have glucose level measured. Liver enzymes and function tests do not need to be routinely ordered, but have an important role in the management of a number of toxins, including acetaminophen. As a general rule, the beta HCG level should also be ordered in all women of childbearing age to rule out pregnancy. The anion gap can be easily calculated from the values in an electrolyte panel. The anion gap is the difference between the primary measured cations, sodium and potassium, and the primary measured anions, chloride and bicarbonate, in the serum. Since the potassium value is generally low, it is often omitted from the calculation, leaving the equation as sodium minus the sum of chloride bicarbonate values. The normal range for an anion gap is between 6 to 14, but typically an anion gap greater than 12 is considered elevated. An increased anion gap suggests that there is an increase in unmeasured anions. These could be either endogenous, such as lactate or ketones, or exogenous, such as salicylates. On the other hand, a low anion gap means that there is an increase in the number of cations. This can include organic cations such as paraproteins in multiple myeloma, or inorganic cations including lithium, bromide, and iodide. It is important to recognize that a low albumin will cause a low anion gap. Negatively charged albumin accounts for the majority of unmeasured anions, and therefore a high anion gap acidosis in a patient with low albumin levels may appear as a normal anion gap acidosis. This probably is not that relevant for the average poison patient coming into hospital from home, but it can be important for certain patient populations, such as those with chronic diseases or those in the ICU. To correct for a low albumin level, 2.5 should be added to the anion gap for each 10-point decrease in albumin. There are a number of mnemonics to help remember the causes of an elevated anion gap metabolic acidosis. The most common ones are metal acid gap, or mud piles. Some people may find it easier to think of the causes of an elevated anion gap metabolic acidosis using the mnemonic CULT, where K stands for ketoacidosis, from DKA, alcoholic ketoacidosis or starvation ketoacidosis. U stands for uremia from renal failure. L stands for lactic acidosis and the many causes that contribute to this. And T stands for toxins, including methanol, ethylene glycol, and salicylates, as well as a list of other toxins that can contribute to an increased anion gap through multiple mechanisms. It really doesn't matter which mnemonic you use, if any at all, as long as it helps you to remember. An osmolar gap is easy to calculate as long as you have a measured serum osmolality. Normal serum osmolality is between 285 to 290 milliosmoles per liter due to osmotically active substances in the serum, such as sodium, glucose, and urea. An osmolar gap greater than 10 suggests the presence of an exogenous osmotically active substance such as ethanol, methanol, ethylene glycol, or other alcohols. An osmolar gap should be calculated in all patients with an elevated anion gap or suspected ingestion of toxic alcohols. Calculation of the osmolar gap will be discussed further in another video session. What about toxicology screens? The use of toxicology tests to detect drugs in urine and serum is generally overemphasized. In reality, most physicians do not rely on the results of qualitative drug tests to make emergent management decisions. Urine drug screens have poor sensitivity and specificity and do not provide information about the timing of an ingestion, since some of the urine metabolites measured can remain positive for days after exposure. Evidence of these ingestions can often be identified by reviewing the patient's vital signs, physical examination, and a trial of naloxone if needed. The urine toxicology screen available in most hospitals are immunoassays using antibodies. The typical qualitative urine toxicology screen consists of a panel of 8 drug classes, including cocaine metabolite, morphine and contraceptives, barbiturates, benzodiazepines, tricyclic antidepressants, amphetamine, phencyclidine, and THC. Some will also have a methadone screen available. Comprehensive urine toxicology testing is done with mass spectrometry and high-performance liquid chromatography or gas chromatography. This is the gold standard to detect specific drugs correctly in the urine. However, it is not as common and not available in most hospitals, making its utility limited. Again, the role of comprehensive urine toxicology tested is limited to specific unusual cases and those that include suspected exposures in children. Quantitative blood drug levels are available for a small number of drugs, typically those that require therapeutic drug monitoring. They can predict toxicity and guide treatment in cases such as acetaminophen, salicylates, iron, lithium, digoxin, anticonvulsants, theophylline, and toxic alcohols. Remember that a blood gas will not give you information about carbon monoxide or methemoglobin levels, and to determine these levels, you need to order co-oximetry separately. There is a limited list of blood toxicology tests that should be ordered routinely in patients with certain characteristics, including those that are unreliable, have altered level of consciousness, suicidality, or decreased mental capacity. These patients should all have a serum salicylate level, acetaminophen level, glucose and ethanol level measured. Evidence supports the routine measurement of acetaminophen and salicylates in all patients presenting with an overdose who are not able to give a reliable history because of the occult initial presentation, potentially lethal consequences, and the availability of effective treatment. There are many indications for an ECG to be done for a poison patient. An ECG may help with diagnosis and management decisions and should be taken in all patients who present with a deliberate self-poisoning or altered GCS of unknown etiology. ECG findings, including prolonged QT interval, wide QRS complex, bradycardia, or tachyarrhythmias, can give clues to the underlying toxin present. General X-rays do not need to be ordered routinely. There may be a role for an X-ray to identify radio-opaque ingestions, bezoars, drug packets in body packers, or complications from exposure to caustics or pulmonary toxins. Imaging should be considered on a case-by-case basis, depending on the toxin and the symptoms. Here are some follow-up questions. Number 1. What is the mechanism of drug-induced QTc prolongation, and name 3 drug classes with QTc prolonging effects? Number 2. Name 7 radio-opaque toxins.